Hello, everyone. Hello, hello, hello. I'm gonna
Good
do,
afternoon.
hi there. All right. I'm gonna share my screen just to make sure. I'm gonna go over some updates for Double Up Indiana here. Oh man. Sorry guys, I'm coming. It's gonna come up in a moment. All right. Share this. This. All right. Can you guys see my screen?
Yep,
It's not in
it's
presenter mode, but I can see it.
correct.
It's not okay.
Yeah, hello everybody. And if you want to put in the chat your organization um, or in any involvement that you may have in food as medicine, feel free.
Okay, I'm sorry. I don't know. Maybe it's because we're in a webinar and I'm not familiar with how to do it in the webinar that I'm not connecting the proper way. I'm going to give it one more try here.
Shalise, you just hit the little your little at the bottom right there, the presenter mode.
Down here?
Yep, right there. It should change for you.
Are you still seeing this? It's
Yes.
still
Shalise,
not.
if you actually go up to the top underneath
Yeah.
file, you'll see from beginning. Just click that and
That's
that'll
what.
get you presenter mode.
You guys, I promise that's what I'm doing from beginning, but it's just not coming up. Swap presenter. I don't know. Okay. Well, I'm gonna I don't know. I don't know the best way to do this. I apologize that this is such a mess right now, everyone. Um, but I do want to welcome you all to our ININ meeting. We just want to go over and share some updates here with you real quick about what's going on in the food as medicine space. And then we will all hear from Katie Edmond on Coding for Food. Very excited to have you all with us today. So what I do want to share today is updates about Double Up Indiana. So everyone knows that our nutrition incentive program, Double Up Indiana, has been partnering with regional partners, and we are finalizing our contracts with Northwest Indiana and in the South Region Urban Seeds in Evansville. And so Northwest Indiana is going to be distributing funding to our farms in the northern region of Indiana. We are coming up on market seasons beginning this weekend, so that's very exciting for us. Um, and funds will be soon distributed to all the farms out there. And also, I should let you know if I have my presentation, you could see that Northwest Indiana Food Council is also going to be hiring for a farmers market coordinator position. So we are rocking and rolling with this partnership, and we couldn't be more excited. And then Urban Seeds has kindly agreed to support our central region firms outside of our Marion County firms who are, using fresh bucks. And so Urban Seeds will be distributing nutrition incentive dollars to our central region firms. And it's just a great partnership. We thank you so much, uh, Maria and for for the opportunity to support Double Up there. Let's see. Another update that we have is ININ will be having a newsletter. We are in the anticipating that the newsletter will begin in May. So if you have any relevant information to trainings, workshops, job postings, informational sessions that you would like for us to share with our statewide network, please feel free to email myself or email Michelle, and we can stick that information in there, you know, and we'll be glad to get that out. So look for that in your inboxes soon. Along the same vein of the newsletter is our ININ network will be having branding. We're going to expand the network, and we're working with our OPA department here at IDOH to develop a logo and get that approved so that you know, we can be recognized in our in this group, and you know, just have that recognition within the state. So that's all very exciting news. I'm going to continue to work on getting this presentation so that you guys can see our next meeting dates. For those of you that participate in Double Up Indiana Community of Practice, our next meeting will be on May 6th. We'll be talking about the USDA's EBT 4-digit policy and just us not being able to collect those numbers anymore. So if you're a Double Up Indiana implementer, please join us for that meeting next Tuesday from 10 to 11 a.m. And then after that, the very next week, Michelle will be holding the produce prescription community of practice, and that we'll be talking about evaluation in that meeting, and that'll be again at 10 to 11. Michelle, do you have any updates before we introduce our speaker?
I do not.
Okay,
Thanks, Shalise.
you're welcome. I'll hand it off to you.
Okay, great. Welcome, everybody, and welcome, Katie. So we have Katie here with us today. I'm just going to do a quick introduction of her experiences and background. So she's a lifelong advocate, and in her role as the Deputy Director at Fulwell, she works to build a healthy, just, and sustainable food system through local and state policy change. And before jumping into policy head first, she worked with the Food Bank of the Rockies in Denver, Colorado, managing the procurement of fruits and vegetables for 30 counties in Colorado and Wyoming. When Katie isn't at work, you can find her eating her way through San Francisco and searching for the best soup dumplings the city has to offer, which that sounds great. So, Katie, it's all yours.
Incredible. Thanks so much. Thank you, Michelle and Shalise, for having me and everyone for joining me. I believe this is not your normal time. It's much later in the afternoon than you often meet. So thank you for accommodating me as someone calling in from the West Coast. I am now going to try to share my screen, and we're going to hope this works. Are you seeing a slide deck?
Yes, we are.
Incredible. Okay, perfect. So before I jump into what we're going to be talking about today, Coding for Food, I'll just start with a little additional introduction myself. So like we said, Katie Ettman, my pronouns are she, her, Deputy Director at Fulwell, and just really excited to be with you all. One of the major campaigns that I work on here at Fulwell is working to integrate different types of food-based interventions. In California, we call them medically supportive food and nutrition, but food as medicine, food is medicine, any language you want to use into our state's Medicaid system, which we call Medi-Cal. And so I actually got into Coding for Food and this work on medical codes, all because of our local and state policy efforts as it relates to the integration of food into healthcare. So that's a little bit about why I'm here and why I'm talking about these things. And so first, we're going to start with a really basic overview, because if you are anything like me, you've never thought about medical codes before. And I didn't know they were important or something that I needed to care about until I got into the nitty-gritty of implementing food interventions in healthcare, particularly in Medicaid here in the state. So first, what is a code and what is a claim? So at a really basic level, a code is a numeric or alphanumeric code that represents a diagnosis, a procedure, a service, or in some instances, equipment. And I think the easiest way I've had to wrap my brain around this is that when you're sitting in a doctor's office, how often is there someone sort of tip-tapping to the side of you? You're talking, you're answering questions, and they're writing down information. While they are sharing, like, oh, Katie said that she has a da-da-da-da, or telling my story, like literally in words, the way we would anyone else, there are also instances where that information doesn't move in a narrative, because we have to make sure that we're telling a patient story, but we don't do that by saying Katie Ettman has diabetes. Instead, that information moves in these alphanumeric codes. And so instead, it would have whatever my healthcare number is. Let's say I'm 1234, and it'll be 1234, and then it will be A692. That is not the actual code for diabetes. But the idea is that we can't just move these narratives about people throughout the entire healthcare system. And so we rely on these codes to tell a patient's story. And it is extra important when these codes relate to claims, which is how we get paid for different services. And so if you're going to say that I received a medication, it needs to be able to move in that claim so that someone can get paid for providing that medication or service. And then when you build on that, when you aggregate lots and lots and lots of claims data, then you have lots and lots of claims, you get huge amounts of data, maybe a better way to say it. And this is incredibly helpful because it means instead of looking at health outcomes for someone with diabetes, 1, 2, maybe 1,000 people at a time, if you have a large enough data set from claims from individual doctors' offices, from hospitals, from entire states, then you have a bucket ton of health information so that you can start doing really large data analysis. So we can look at efficacy, we can look at cost effectiveness, et cetera, when we have all of this information that's aggregated in this way. This all often happens through electronic claims or e-bills. And so every time I'm convinced that someone talks about faxing healthcare information in California, I die a little inside. And so it is really helpful to know that these claims don't always have to be a paper trail, but instead information moving electronically. So that's the baseline. What is a code? What is a claim? This is what we're focusing on today. And then unfortunately, or fortunately, depending on your perspective, there are lots of different types of codes and they fit into different terminologies. And so you'll see here in the what, there's LOINC, there's ICD-10, CPT. All of these different terminologies have different purposes and are managed by different people. So I think the one people are most familiar with is often ICD-10. So it's pretty much the example I've given already. It's diagnostic. It is exactly what issue do you have? Is it hypertension? Is it diabetes? And that is managed by the US extension of the WHO. And then one where people are also relatively familiar often is they've heard the word CPT. And so those are medical services and procedures. So imagine you got your appendix out. There's a code that stands for getting an appendectomy. And those are managed by the American Medical Association. But the one that we really care about in the food as medicine space and coding for food is this HCPCS level 2. And these are a lot like CPT, but they're not inherently medical. Instead, they are medical related services and procedures. So an example of that is an ambulance ride. So you need to go from your home to the hospital, you take an ambulance. It is not in and of itself medical, like getting your appendix out, but it's certainly related to your medical care. And that falls in this HCPCS level 2. And so because we are talking about the integration of food into healthcare, that is sort of the arena in which we like to play. It's also very helpful because it's managed by the Centers for Medicare and Medicaid Services at the federal level. And so these are codes that are free and open for anyone to use. And so you don't have to pay a servicer to access these codes and use them to share information and submit claims and do billing. Also, if you're already like, wow, this is a lot of information, I just like to remind people that 2 years ago, I knew absolutely nothing about medical codes. For the longest time in my head, I read that at HCPCSs. Only once I started talking to experts and learning from them did I realize we call them HCPCS. And so while it starts complicated, I promise it gets easier. And when you want to think about it, while I'm giving you the details, the terminology names, all of the different ways they interact and who manages them, at the end of the day, this slide is what it's all about. Terminology and medical codes give us the ability to share a patient story. And so you might use LOINC, screening and assessment codes, to find out if someone has food insecurity. So that's asking a question and getting answers. And those answers, whether you're food insecure or not, could be coded in SNOMED CT or an ICD-10. You might do goal setting. So how are we going to overcome that food insecurity? And then there's actual interventions. And so what's important to note here is that we don't have all of the interventions that we know support people's health in the food-based world within the existing code set. And so right now, we do have a HCPCS code, S5170, sort of over in the top left of the screen. And this has been the absolute workhorse of the food as medicine movement. Anytime someone has needed to code for providing someone food in a healthcare setting, it has pretty much gotten lumped under this S5170 code. Home delivered meals, including prep per meal. But like many of you know, it's not often that simple. So it could be a home delivered meal, but you could also be providing someone a produce prescription. And so that's where we're living in this procedures HCPCS world. So that's a little bit about sort of claims and coding, and hopefully that gives you a foundation so that we can understand Coding for Food, the project we're here to chat about today. So I've done a little bit of this, but what's the problem in the process to solve it? It's that lack of medical codes to accurately describe the full spectrum of food as medicine interventions. So instead, we're ending up in a world where documentation in our medical records isn't actually accurate. You're not telling the full story of a patient, which means that we can't fully support their health needs. It also means that in some instances, we're creating parallel systems to pay for these services in healthcare. So healthcare is over here using codes, using e-bills, like claims data is moving. They're creating all of this information. And then all of our individuals who are trying to get these food-based services paid for in healthcare are maybe invoicing health plans, or they are using codes that aren't actually the right alignment. And so they're using modifiers on top of those codes to share more information. And so instead of this true integration that I think we're often all fighting for, there's this separate system. It also means that we don't get access to that large scale data, which we know is so important for research. And then unfortunately, because food as medicine has grown so much in the last few years, it's led to the rise of state-based solutions. So I will tell you that California and Massachusetts are two states that are using codes to pay for these services, but we're using them differently. So in California, we're using a different code for medically tailored meals than in Massachusetts. And so instead of being able to aggregate all of that data, we're instead saying, wait, we're comparing apples and oranges because we're not using the same type of information. And so this is only getting worse when you look at states beyond California and Massachusetts. So here in front of you, you will see many names for similar services. And so I love to point out this sort of orange box here. And so this is language that shows up in either federal waiver language, so people who have gotten federal flexibilities to pay for food-based interventions in their Medicaid program, or an implementation guidance, or sometimes in national reports, for example, things done by the Aspen Institute. And you'll see here that language includes nutritionally appropriate food boxes in Massachusetts. But then in Michigan, we call it a healthy food pack. We've always sort of assumed those are similar services. But what's the difference then between that and pantry stocking or short-term grocery provision versus just grocery provision in Illinois and DC? But DC also offers protein boxes. And so with all of this different language floating around, we're not helping to build a concise narrative for the food as medicine movement to share. And when we're not speaking the same language, we're not necessarily all moving in the right direction. And so not only can we not bill for and get paid efficiently and integrate into healthcare, we're also not even able to talk necessarily across state lines about the types of services we're providing. And so we can't compare them and we can't get to that aggregated data level. And so by getting these new HCPCS to describe this full spectrum of food-based intervention, there are tons of different benefits. Gone through a number of them. Actually telling a patient story, the shared language that we just talked about. Standardized service definitions, which not only helps with better data collection, but it also leads to the analysis based on all this claims data. Simplified quality reporting. So instead of having to go through and be like, well, what type of produce prescription was it? Instead, you just like, oh, we all know what a produce prescription means and we know how to measure it. Billing and reimbursement, streamlined and integrated payment. And then because these are HCPCS level 2 and managed by CMS, the Centers for Medicaid and Medicare Services, they can be used across different types of insurers. Medicaid, Medicare, private insurance, they're really deeply accessible. And then obviously this is all towards the goal of integrated services in healthcare. So that's why and how Coding4Food, this national project, was born to solve this problem, that we don't have shared language definitions or codes. And so we launched a round of advisory work groups, expert work groups, back in 2024. And what they needed to do was come up with the definitions for these different food-based interventions. Why is it a medically tailored meal? Why is it not a medically tailored grocery? Why is it this, not that? What's the difference between medically tailored groceries and healthy groceries? And how do we define those different services? Because that is the core of a new code, is that essential definition. And so we've done this in partnership with a national group called the Gravity Project, who are absolute terminology experts. They are the go-to. And so they've actually created other codes and applied for them in different instances. And so while we brought together the expert work groups as the Coding4Food project to help manage, we also worked with them because they have a national consensus building process where expert work groups come up with these definitions, they hem and haw with one another, they go back and forth about what it should look like, but then they also present to this Gravity larger community, which is thousands of members across the country who are able to come to these public meetings where you share a draft medically tailored meals definition and they provide feedback. We think you're missing this, or what about that? And so it helps us get to a place where these codes have not only been vetted by individual experts that we've pulled together, but also the broader community who cares about medical terminology. And this is really important because these codes don't just affect California. They don't just affect Indiana. They affect us all. And so we need to make sure that we're reaching that consensus. And so these groups went for about 6 months, came up with those definitions, and then submitted those individual definitions to CMS in January of 2025. And so now I'm going to go through those 4 different definitions with you briefly. So first, here we have medically tailored meals. I'll be quiet for a moment while you read it. So, as I shared with you before, we have S5170, home delivered meals per meal, including preparation. Much of the medically tailored meals community told us that that code wasn't specific enough and that it didn't actually reflect the level of effort that goes into creating medically tailored meals and providing this service. And one of the things that we ran into is that HCPCS, they are service product codes. They are a physical thing, in this case, a meal. But so much of what was tied to medically tailored meals is this inclusion of a registered dietitian or an RDN or other nutrition professional. And so we had to come up with a nuanced way to share that this is about the meal, but it's also about the fact that it is based on this nutrition assessment that can be done by an RD. And so the group went back and forth about all of these different aspects. And so, for example, here, you'll see prepared using natural foods. If you didn't know, there is no national definition of a natural food. And so it actually says that if you want to use natural, it is up to you to then define it. And so that's what we did. So we looked to USDA and FDA definitions and found this USDA definition about nothing artificial or synthetic, etc. And part of the reason this was so important to the group, there were discussions that we would never want a medically tailored meal to look like that blue goo that you squirt into your mouth during a marathon. That's not what we're getting at. And so it was this level of nuance that was really important for our group to pull together so that they felt confident that it was really truly representing what a medically tailored meal is and what it takes to make it an effective intervention for people who receive them. And like I said, these definitions first go through an expert work group. And so here are just some of the organizations. Here's the organizations that were represented in those expert work groups. And then from there, it was shared out with the broader community. And I do love to point out that these are generally representative of for-profit and nonprofit, different states, including most of the states that have active federal waivers allowing for the payment for these types of services, rural and urban, et cetera. And then our next definition, medically tailored groceries. You will see here a very similar through line as it relates to the medically tailored meals definition, still that inclusion of an RD. It talks about that 1/3 comprehensive recommended intake for a person per week. And so it gave us the unit. How much of a thing are we talking about? When you're talking about a meal, it's relatively simple, at least you would think. Like we all generally understand what a meal is. But if we're being honest, we also talked about, is a meal not 1/3 of a comprehensive intake? Instead, is it a protein, a carb, and a fruit or a vegetable? Does that need to include dairy? What about if an individual really needs small meals and then snacks based on their chronic condition because it's hard to eat large meals? So one of the things we had to get to was the unit. And so that was particularly important for medically tailored groceries because you're going to bill for these and talk about them in units of service. And so in this instance, based on expert feedback, we came to that, like I said, 1/3 of dietary intake, but for one person per week. The idea that often these are provided a grocery box on a weekly basis, and that's how you might be able to bill for them in the future. And the idea is you can always add more. So whatever that code is, you provide multiple units of it. So let's say 2 people in the same household have both been diagnosed and recommended for a particular service. It's been approved by their health plan. They could each get medically tailored groceries. And so it would be the code times 2 for that individual or for that person receiving those services. So that ability to build these up to really define the service that's being provided. And then similarly, our medically tailored grocery experts with all of those same caveats. And then our third definition, healthy groceries. So what you will see here as we talk about the definitions, why is it this, not that some of the nuances between medically tailored groceries and healthy groceries are that RDN assessment and tailoring to a particular chronic condition versus this instance where this is really meeting the dietary guidelines for Americans. So we're not going down to, oh, well, Katie Ettman has hypertension and diabetes and gestational diabetes, whatever those overlapping chronic conditions might be, and meeting with that RD. Instead, this is saying this is generally healthy for the people who are receiving them. And you'll note that these get so in the weeds that we had to reference the FDA standards of identity because we're always pointing to other national standards. And so those FDA standards of identity get so specific. So imagine that you are buying a can of artichoke hearts. The FDA standards of identity tell you what can and can't be labeled a can of artichoke hearts based on how much of that can is actual artichoke heart versus stem versus liquid versus leaves. And so it gives us a way to point to other standards that are then reinforced through our applications for these new codes. The healthy groceries group, actually definition was born out of the medically tailored groceries group. And so they actually ended up coming up with both definitions because they realized through conversations that they weren't describing the same service and that not all of them use that same level of tailoring. And so those same experts helped us reach 2 different submissions to CMS. And then last, but certainly not least, and likely the one that is of most interest to this group, our produce prescription definition. All right. You will see this one gets pretty wonky pretty quickly. And honestly, that's because we see so much variation in how produce prescriptions have been operationalized out in communities. You'll note here that it is very often that food banks use pounds as one of the ways that they measure their outputs. While other instances, people use cups because we measure fruit and vegetable consumption in cups. And then there are also instances where this happens with vouchers or paper coupons. And so what we really came to is that at a baseline, a produce prescription is the provision of produce. Great. But there are lots of different ways to go out there. And so the group spent a lot of time making sure that the definition was encompassing of all of the different programmatic designs to make sure the people who are providing this service weren't going to be excluded from their ability to use this code when working to integrate into healthcare. Similarly, USDA callouts, the FDA standards, the WIC guidelines, et cetera. So to that same point, always pulling to make sure that we are referencing other groups. And so here are our produce prescription experts. I think you might recognize someone on the top of that list. And they all helped us get to this place. And so, like I said, these were submitted to CMS in January of 2025. What happens is they go through and review those applications and then ask us any clarifying questions, either to us or to the Gravity Project who supported this and submitted those on our behalf. Thus far, we have not received any questions from CMS. And then after that application process, there are sort of two additional opportunities for public engagement. One is that if and when CMS agrees to bring this forward to the HCPCS Level 2 public meeting, of which there are 2 every year, people can share public comment. And I will note that while our submission was in time for the May 2025 meeting, we have yet to get any indication that we will be represented at that meeting. Unfortunately, if we do hear about that, we will certainly share that out via our Coding4Food listserv, which you'll see a little bit later. So still crossing our fingers, but likely getting pushed out a bit further than that. And then after that HCPCS Level 2 public meeting, if it moves through that process, it goes on to the Federal Register, where there is now another opportunity for people to create public comment before anything is finalized and these new codes are able to be used out in the world. So that was phase 1. You saw that we asked for 4 new food-based interventions. I will say, at least in California, we often talk about there being 7 different interventions, and there are lots of different states that slice and dice these differently. And so for phase 2, we went through the same process. Expert work groups meeting for about 6 months, getting ready to submit applications, and then also working with that Gravity process public call so that people can come and share their thoughts. And so the 2 work groups, the first one you'll see here, cooking education, teaching kitchens, food pharmacy. It's a mouthful. And that is in part because one of the things that we talk through in this work, why is it this, not that? And so in lots of instances, we saw a lot of overlap in programmatic implementation for programs that were called all 3 of these things, teaching kitchens and food pharmacy. They were often teaching things like knife skills in person. Sometimes they included the provision of food, sometimes they didn't. And so we lumped these groups together to come up with what are the similarities amongst them? Are they all the same intervention? And if they are, we need to come up with the umbrella term. And so by way of a metaphor that hopefully helps figure this out is that we're looking to define a tissue. Why is it a tissue, not a paper towel? Once we define a tissue, someone can call it a Kleenex, someone can call it puffs, but it doesn't change the definition of a tissue. And so we do not yet know what the umbrella term will be for these three interventions, but we're working towards it and finding out those commonalities for a definition. And then we're also looking into cooking and kitchen supplies. This is most often a provision in Massachusetts and New York, but where people can actually get things like pots and pans or a refrigerator so that they are able to utilize the food that they are receiving to support their chronic disease management. And so we had a request for application back in November, closed applications in December. People were accepted to those expert work groups in January, and we are obviously deep in meeting with those expert work groups with a final submission to CMS planned for July of this year, so that second application period. And so if you have gotten 37 minutes into this meeting and you're not exhausted and you don't think that coding is the most boring thing you've ever heard and you don't know why you appeared here, we would love to have you join us in this work. So you'll see that those Gravity public calls I was speaking about happen every other Thursday from 4 to 5:30 Eastern. You can get the details for how to log on to those via the link on the screen. And so we are actually down to our final 2 public meetings. So the next one is May 8th on that Thursday. And that's where we'll be bringing pretty close to finished definitions for final feedback. And then for folks who have been engaged in the process throughout these months, there's a final consensus vote that happens on the 22nd. And then if you are like, oh, don't necessarily want to make those meetings, not ready to get into the nitty gritty, but I am interested in like, did CMS ask you any questions? Are you going to be a part of the public call? Hey, have these been approved? You can sign up for the Coding for Food email list on our website listed here. And now we are getting to actually my absolute favorite part of any discussion, which is questions from you all. So I know we've just got about 20 minutes, and I know there is a Q&A function and a chat, and I'm happy to try to look into both of those. And so I will give you a moment to pull them together, but I will warn you ahead of time, I will lean hard into an awkward silence because it is way more fun to hear from you than it is to hear from me.
Katie, thank you so much. Yeah, the question in the chat was if the slides would be available. So if you can share them with Shalise and I, Shalise can get those out.
Great. Yeah, happy to have those shared publicly. And I see a hand, and I believe that's Frida.
Hi, good afternoon. Good morning, everyone, wherever you're at. Good morning or afternoon. Let's put it that way. I have a question on the medically tailored boxes and medically tailored meals, particularly the medically tailored meals. Were any the dietitians, did they mention the NOVA scale, the minimally processed scale, the 1 or 2 on the NOVA scale, as far as the boxes are the medically tailored meals?
Yeah, so I will say there was lots of discussion about sort of ultra processed foods, whether that related to, honestly, even in the produce prescription world, talking about like canned, frozen, what counts, like USDA minimally processed. I believe the NOVA scale came up at one point. One of the things that we struggled with, particularly in the meal provision space, is the idea that for some of these instances, like we have a provider here in San Francisco, California, where they mechanically soften the meal because someone can't chew or eat. And that depending on which definitions and what you're looking at, like that is definitely processing of food. And so while there was discussion about implementing one of those items, it didn't feel inclusive enough to all of the different types of providers. And that's why it was ultimately left out of that definition.
And then I see that you used the hunger vital signs on some of your, when you ask about the food insecurity.
Yeah.
Did you use the 4 question or the 6 question hunger vital sign?
So totally. The hunger vital signs that's used in reference in that telling a patient story slide is really just an example. So one of the things that is both great and complicated about this is we are solving one like really niche problem, which is we don't have medical codes. But the reality is we know that this is interconnected to like a giant system of healthcare and food insecurity, et cetera. And so, for example, in California, you don't actually need to be food insecure. It's not a qualifying criteria to access a food-based intervention through Medicaid. And so while we use that as an example criteria of telling a patient's story, we have given no preference for what hunger vital signs questions you use, if you even need to screen for food insecurity. That's sort of outside of the scope of Coding for Food. It's just a way to support people in understanding why that information is helpful and why we need these codes.
Yeah, I'm just amazed at the fact that food insecurity might be a possible code. That's what I think I was looking at, because that's interesting to me. Okay, thank you for your answers.
Yeah, of course.
Katie, can I just add to Frida's question on that? One of the things I think what happens is the hunger vital signs are typically asked within like the EMR systems of a healthcare system, whereas the short term or long term USDA questions that we're used to asking with like GusNIP are completely different. And so I think, I don't know if that kind of gets to what you were asking in there, but within like an EMR system or EHR system, it is typically the hunger vital signs 2 questions that are asked.
Yeah, that's what. And I actually had those added to my GusNIP. They actually added them for me because of the
Nice.
demographic that we're in.
Yeah.
Oh, that's incredible. And that does remind me, I know, and this is where we are at an interesting intersection, right? Obviously here as it relates to USDA funding and GusNIP. And there was guidance out from the Centers for Medicaid and Medicare Services talking about the ability for states to limit access to these based on those who have very low food insecurity, as defined by the USDA scale of asking folks about their food security levels. And we also understand that that is not a direct proxy to the hunger vital signs. And so understanding that because we're working in different systems, USDA versus CMS across different departments, that sometimes that falling down of language and communication is a problem. And it's part of the reason I see this like coding for food and coming together around shared definitions is so important, because at least if we as outsiders, whether you consider yourself an advocate or a program implementer, can be speaking the same language, we can encourage our federal parties to also be speaking the same language. And I see a second hand, Deepa.
Yes, hi. And maybe, and this is just a thought. So I work in public health and serve the underserved population with a lot of cultural diversity. And in the past, when we have run the produce prescription type of programming, one thing was very obvious, that the food that was being offered or given, if it is not culturally applicable, it acts almost as a barrier. So is there any thought process along the line to make these things from the, I mean, is this even a place to make it, or rather ensure that there is a cultural component is injected into this effort?
Yeah. I love that question. And honestly, you sound exactly like all of our expert work group members. I can't tell you how many over the course of those 8 to 10 meetings that people brought up cultural relevancy or respect for individuals' cultural preferences, or even just food preferences. You know, I talk about this all the time. It took me 30 some years to learn to eat mushrooms. Now I love them, but it was practice. It was hard for me. And so understanding that if someone handed me a bag full of mushrooms 15 years ago, I wouldn't have eaten them, so it wouldn't have helped my chronic condition. Like, it only works if you actually eat what's provided to you. And so this came up all of the time. And so we often talked about sort of cultural relevancy needs to be baked into these at a programmatic design level. But for our ability to say point to standards that define different cultural relevancy and include that in a code application, this wasn't the place for that type of information. And so instead it lives in, as you, a program implementer, know your community, you're going to use the same billing code, whether you are providing a box that supports someone from the Hmong population or someone that is Latina, for example. And so the code will be the same, irrelevant of how you tailor that food to an individual's needs, preferences, and culture. But you at an individual programmatic level can meet people where they are.
All right. That's good to know that somebody else is, I mean, people like you are at a high level are at least thinking in this direction.
Of course.
It's
The other,
important because what I have seen with, let's say, I happen to scan through the list of foods that WIC offers, and up there it says, oh, you can offer quinoa but not millet, and it just doesn't make sense. You know, why would they not offer millet along with quinoa? So, but again, I just wanted to just vent here a bit, that this is a need, but thank you for listening.
of course, I love that. And I will add, in our second phase work groups, I shared with you one of the things we're looking at is cooking and kitchen equipment. And so there was a discussion. We brought a definition that included examples of particular types of equipment. So saucepans, mixing bowls, spatulas, all sorts of utensils. And someone noted, you didn't a rice cooker? Like, would that work? Someone then also brought up chopsticks. Like, if you don't call these out as examples of these types of supplies, you could be losing out on large portions of the population. You're like, use a rice cooker every day, whose primary utensils, both for cooking and eating, might be chopsticks. And so we know that we have these blind spots, and we wouldn't have gotten those recognized unless incredible experts showed up to those public gravity calls and were like, hey, you're missing out on something. You're not telling someone's story. You're being too narrow. And so it's been really incredible to get these pulled together, not just by the work groups, but other people who are willing to learn along with us.
Okay, so on that note, if there is an opportunity for me to volunteer my time to discuss specifically these kitchen appliances and pantry staples, as I call it, or like master pantry list, which includes all different things, I might be able to provide some insights because I travel around the world a lot, and I also work with an extremely diverse population and have been in the houses of people of different ethnicities and really understand how their kitchens look. So if there is any opportunity, I would love to share that when the time is right.
I love that. And so I will pop into the chat here, but it was up on our final. Oh, maybe I will. Okay. Not sure why I'm fighting with the chat currently. But I can share the last meeting to share insight like that will be coming up on the 8th. And that is that gravity public call. And Michelle and Shalise, I can make sure that I get that information to you for a follow-up email if that's all right.
Oh, that would be fantastic. I'm driving, so I cannot send you my email address, but Deepa, my name is Deepa. If you see my email address in your roster, just email me or just keep me posted. I would love to finally be happy to share this knowledge that I've been keeping up in my brain for 20 years.
I love that. Thank you so much, Deepa.
Thank you as well.
And I spy another hand, Rebecca.
Yeah, so we do a food as medicine program. I work for a hospital, and we do that in partnership with Purdue Extension. And a lot of the things that you touched on, we work on. So they get small incentives such as cutting boards, knives, things like that. And then they get a large incentive at the end, but it's based on their specific health needs. So they can kind of basically prioritize their need. The other thing that we do is, like, typically the first or second night, it's a 12-week program, we give them a spice set. So they have basic spices to be able to do a lot of just basic cooking with, because what we've noticed is a lot of people, if they have cost barriers, spices do not get added in the grocery list.
Yeah, I really appreciate that. I will say one of the things that came up relatively frequently when discussing both our healthy groceries, but also this supplies and kitchen piece, which is programs are providing medically tailored or healthy groceries to individuals, but often, exactly to your point, those spices aren't there. And so often our community-based organizations who are contracted to provide these services are doing the equivalent of like a welcome basket that has spices and items up front, and those aren't necessarily being reimbursed by healthcare. The rest of the food is, but as community-based organizations who are not just here for a profit motive, they are sort of part of the community, and they have a social charge, are doing that. But we think there is certainly flexibility in the actual food provision piece, so in groceries, to potentially be able to cover some of those items. And then it would be generally a separate code for those like physical goods, those supplies and equipment is how we divided it. But it is funny how quickly we get to that overlap. Someone's like, oh yeah, I give them 7 meals a week, but I also provide $40 a week in produce prescription. It's a combo to best meet their needs. And so there will always be some of this like, how do we operationalize this in a world in which like people aren't just black and white? Like we don't just have one chronic condition. We don't just go grocery shopping and or only cook at home. So it's been interesting to see that.
Yeah, and we've been grant funded, and I will just say, like this would be great to get anything funded in a regular manner, but I will say the way that we do it, it's very much a medical home model. So they have a support group system set up in this because what we're really asking them to do is to make huge health behavior changes. So it's great that they have a support system set up, and we do a lot of pre and post surveying. And one of the things we noticed from our very first pilot group is people don't have a support system in their eyes. They don't have a support system in place in order to make these health behavior changes. And we know if there's not a support system in place, the likelihood they're going to change is not great.
Yeah, that has certainly come up in our teaching kitchen, cooking education space. Feeling like that space to be able to do this, not just as individuals, but to have group options for that behavioral bit. Other questions, either in the chat or if you want to come off of mute and say hi.
Katie, I will go, maybe this will spark some questions, but I will just mention as far as what our role is here at IDOH when it comes to food as medicine is to really build out these standardizations. So that slide that you had, excuse me, what's going on with my throat? The slide that you had with all the various names of programs and projects, I mean, that is no different. I know in every state, but it is no different in Indiana. You know, I'm in the works of creating a survey to do a robust landscape scan of the various interventions and intervention types, really analyzing that and seeing, you know, the various programs that are happening. And I think the advantage that we have for Indiana is that this work is happening already, that we can then align with this language and standardization for our interventions in our state. And really setting up healthcare systems to really operationalize this within their systems for sustainability and financial stability, and kind of getting over that, ending that funding cliff that we're always constantly falling off of because we're having to braid and weave. I also think that during this time, as we continue as a state to provide some guidance and bringing partners and working groups together to do this work. In the meantime, there does have to be that buy-in, though, and there has to be some investments from our healthcare systems, especially for the cost of food, because we can keep leveraging federal dollars where we can, but a lot of it doesn't pay for food. You know, whether that's through even private funders and stuff that you can, is that responsibility of the food cost. But with capacity and administration, you know, I think that's where we can really leverage the funding to support this work. But we're here to help guide, and we're hoping this network will continue to provide information and insight. And I know it's a complex world, and Katie, I really appreciate you taking the time to share with our network this information as we continue to explore, you know, what this looks like in our state.
Yeah, I really appreciate that. And I just want to name, I think, right, it is very common, sort of philanthropically funded, like you're moving towards healthcare paying for these things. Like integrating into healthcare is not easy. Anyone who tells you it is hasn't tried it before. We have these huge systems with all sorts of rules. But with the reason that we've been so committed to it in California and why we've done this is that like it really is the long-term sustainability of what these programs look like. And we know they improve patient health and in some instances save money. And so I do really appreciate your call out of like aligning with some of these national definitions as they get improved will only make it easier in the long term to transition your program from philanthropically funded to healthcare funded. And so, an instance of that, just to make it really tangible, which is if right now you're like, oh, we actually provide a daily voucher for fruits and vegetables. I don't think this is anyone's program design, but you never know. And you're like, oh, instead, it really talks about the provision of produce for a week. Like, transitioning, can you make it so that your program design is no longer set up on a daily basis? Can you take the time now to be like, oh yes, if a healthcare entity asked me to bill for this every week or to bill for 4 instances of this over the course of the month, could you do that now so that when you're in negotiations with a health plan later, you're going, oh yeah, of course I can do that. Done. Easy. Don't you worry about it. Instead of going, we've always done it for a day. Like I have to change my Salesforce and I need to change the verification codes on my cards, or I need to change the scan code on the voucher. I think it'll just sort of streamline these over the long term, and understanding that doing that when you're not in a panic seems like a whole lot more fun than when you're panicking to get things right, just about right. And I do see another question in the chat, and it'll likely be the last one as we're closing out here, which is, my area is a food desert and has just one supermarket for 400 square miles. So how do we implement something like this? And you may have mentioned this, but I have had to pop in and out during the meeting, sadly. Please, no worries at all. So yeah, I will say that's part of the reason that we are in Coding for Food advocating so hard for all of these different codes. So by the end of this, we will have requested at least 6, but at this point, it's looking like 7 or 8 new medical codes. And that is because we want healthcare professionals to be able to match the acuity of a patient's condition to the intensity of the intervention provided, and that you have multiple options. So let's imagine you are in a food desert and it takes you an hour and 20 minutes to get to a grocery store. A produce prescription that is a card or a voucher that you have to go spend at a grocery store on fresh produce might be a really not good fit intervention, because you're going to buy a ton of fresh produce because you only go to the grocery store every 3 weeks, and tons of it's not going to get eaten, or you're going to have to process it all. So you're like, ooh, maybe a produce prescription doesn't work in your particular instance. But maybe with a company that drop ships produce boxes that can do that on a weekly basis, that's a much better fit for you. So instead, FedEx or UPS or whoever it is, because you're in a rural area, drops it off to your home. And so you're not expected to drive that hour and 20 minutes to the grocery store. And so we know that you need access to more fruits and vegetables to support, let's say this person has uncontrolled hypertension or has hypertension, my apologies. Both of those instances can help their health. Both of them are likely cost-effective alternatives to other types of interventions, but one of them is a better fit for their lifestyle. And so by coming up with codes that represent all of these different ways of providing services, we're making sure that that patient has access to the one that works for them. And so it doesn't have to be, oh, you have to go to a grocery store. It could be a home delivered box. It could be picked up from a food pantry, maybe that's closer by. It could be meals because you can actually stand up and cook for yourself. But we only get to offer all of those different types of interventions if we define them and can code for them. So I'll leave you on that bit. And now we are right at 10 o'clock. So I'll throw it back to Michelle and Shalise and just thank you all so much for spending the hour with me.
Thank you, Katie. Thank you for your time and your effort and your research. It's been great. We've got a lot of thank yous in the comments here. We'll give you back your time. We are at time 1 o'clock. Please feel free to reach out to myself or Michelle with any questions. Again, we will send out the recording and the slides to each attendee. Thank you.